And our next speaker, I'm looking to see whether he's coming up, is Dr. Khoruts here. There we go. And I've not had the pleasure to meet you. This is Dr. Alexander Khoruts from the university, who is going to talk to us about basically fecal transplantation. Welcome.
Thank you so much. Thank you for the invitation and opportunity to speak to this audience about this topic that you may see quite a bit. I wish they gave me more money. I'll start with the take-home message since I only have 10 minutes. So this is not my first time to give this talk to this audience, and I was a little more sheepish in the past because the standard therapy for this disease has been colectomy. So given that I only have 10 minutes, I'll just say, nope, that should not be the first-line therapy. FMT should be the first-line therapy at this time. This is a disease that is associated with high morbidity and mortality. And main point here, and this is not really the fault of the surgeons, this is on the medicine side, is that this disease is just not recognized early enough. And then when you're faced with this, virtually always you think back and like, how did they let this happen to this point? So I wish actually we're going to be giving M&M to the medicine people because I think that's where most of the problem is. So C. difficile, you're familiar with it. There's many different strains, and we know that it comes in many different forms. Most physicians still think of it as perhaps the kind of a post-antibiotic nuisance, and often is, of relatively mild symptoms, so the patients will argue with that. It is pretty violent diarrhea with a lot of fecal urgency, fecal incontinence, etc. The severe infection is defined by some extra parameters, like dropping serum albumin and a white count and some tenderness. And then we have this name that I never liked, severe and complicated. 2 words. Basically, patients are sicker and there's some evidence of end organ damage and systemic signs. But now we are rid of this severe and complicated term because, the academic physicians, they need something to do, so they keep changing names. So we're back to Fulminant. Fulminant is the official name now for this presentation, which is the topic of this talk. We don't know whether it's the patient, the host, that is the problem as to why it becomes severe, or there are certain strains that are more toxigenic. It's probably a combination of both. The surgical literature is mostly retrospective. We know it's a highly fatal disease. This particular series was from the epidemic that happened out east about a decade ago with this presumed hypervirulent strain, NAP127, and they observed about 50% 30-day mortality with the fulminant presentation. And importantly, like 40% or so died within 2 days. And some of the signs that would predict mortality included this extremely high white count, greater than 50,000, increased lactate, high age, and use of pressors. If we drill down a little bit of what happened, who had the operation and who didn't, obviously this is retrospective, not randomized, so somewhat healthier patients went to surgery and somewhat sicker ones did not. And so the ones where we see the p-values are low, is the immunosuppression, for example. Well, more of the ones who didn't make it to the OR were immunosuppressed. They had, let's see what else, lactate, for example, higher so the sicker patients probably are felt to be just too sick to go to surgery, is my guess. And the 30-day mortality was a little better with the operation, with the caveat that it was probably somewhat healthier patients. But things didn't look very good at 1 year. 2/3 didn't make it. And after 5 years or so, the majority were not alive. All right, I'm not sure why this out of focus slide is here to supplement anything. Other considerations when you see a patient like this, who's probably older, virtually always they've received antibiotics for something else. Commonly, just because they look sick, physicians just give them more antibiotics. It's the wrong thing to do for C. diff, but things look bad, and you can't necessarily fault them for throwing broad-spectrum antibiotics on board. And so that usually is the case. And obviously, you're seeing them because they have severe disease. If they do make it out of here, out of this hospitalization, over 90% chance this C. diff is going to come back. So that probably is part of the calculus. You're not just treating the acute problem. Of course, if you remove the colon, you're done. But if they're going to make it, you're probably not done. And now we have a little bit more data on FMT. This is a European study that's fairly recent, kind of also retrospective, a cohort study, and they looked at 3-month mortality, and these are inpatients who received FMT at various levels of severity. And if they had severe disease and they received FMT, whatever else happened to them in the hospital, they had colectomy or they just died or whatever, those who had severe disease and received FMT, the majority made it. Those that did not, half of them did not. If the disease is mild, not surprisingly, you're not going to make much impact acutely. I generally look at this when I see a patient like this. I remember to take out the Atlas score. That's the original one and from 2010 that was presented as an abstract. Atlas stands for age, temperature, leukocytosis, albumin, and whether they got additional antibiotics that's not for C. difficile. And you add up the points, and if they have all of these things, they're not going to make it at past 30 days. Now, this graduated to a publication. They added serum creatinine as a kind of an indicator of end organ damage. You can add up these points, and there is an equation, 5.8 times the score. Let's say this is 2 points for each one of these. That would be 12 times 6. Get up there close to 100% mortality with 30 days. Okay, so our approach to this clinically with FMT is two stages. And this is one of our early patients, and it more or less represents what would happen in most of these. So we were pretty academic at that time. This was our patient with pseudomembranous colitis. We're doing a colonoscopic FMT, and we're following CRP level. You could follow the white count as well. And there's a pretty remarkable drop in the CRP. The response can be very dramatic. And then I remember this patient, at about day 3, he was a little hesitant on whether he's still improving. He was quite ill here, and clearly improving, and then it stalled. And we were just held our guns. Yeah, it should work. This was going great. And then it just kind of started getting worse again. And C. diff was still negative, and then it's positive. We restarted vancomycin. We've learned that it needs to be a sequential procedure. There's a part 1 and there's a part 2. The part 1 is you're just trying to knock down the severity, you're trying to get him out of the ICU, convert him back to an outpatient kind of a state, or at least a state where you can treat him with oral antibiotics. Part 2 is consolidate that. So this patient then came back a couple weeks later, received another infusion of microbiota, and that prevents recurrence. in the future. And that essentially is our protocol. There is this Fischer Protocol that is published and is commonly referred to. Comes from Indiana. It is the more patients were published with this, and Monica feels at this point that there's not going to be a randomized trial of FMT versus colectomy because she feels it's unethical. The FMT people just do so much better. You shouldn't be doing surgery unless it's really end stage and the FMT already failed. Her protocol, I feel, is a little messy because there's vancomycin concurrently given with the microbes, and they're kind of fighting each other, and she's doing repeated colonoscopies, and if she sees pseudomembranes, she infuses more microbes, and once the pseudomembranes are gone, then victory is declared. It works. So that's her data. She published the last in 2017 on 57 consecutive patients in Indiana, still using this term of severe complicated. So there was a mixture of severe and fulminant. Severe did better, but fulminant did really well as well, with no severe adverse events associated with the procedure. These are very sick patients overall. A typical patient that in our cohort has a page long of comorbidities. So I'm not surprised that survival is still tenuous. This is our program. I believe we're actually, at the moment, we're the only academic center that manufactures this material under GMP protocols. This liquid material that would go colonoscopically. And we also manufacture freeze-dried microbiota in form of capsules. You can't give that to really sick patients. So the first application is with a liquid material that can easily go through the colonoscope. It's frozen, so it's banked. My sense is that probably the way things were done back in the day of Ben Eisman in Colorado in the late 50s, or Wangenstein in the early 60s here, well, you probably were blending fresh poop, that it was working faster than this frozen stuff. That's just my personal observation. The very first patient I did was, she had chemotherapy for cancer, she had the severe disease, was in the ICU, on the ventilator, on pressors. We made fresh material, infused it in, and I stood at the bedside and actually literally saw the pressors being dialed down, the ventilator being dialed down. It was quite dramatic. I don't see that with the frozen stuff. It seems to require like 12 hours to wake up. But then things start happening. And it's always available. So just practicality is that these days you're just not going to have fresh material made on demand from some sort of a predetermined donor who's been screened and tested and all of that. So we use this, and generally that takes down the severity. They can leave the ICU. On day 4, they start vancomycin again, because if they don't, it's going to come back. And then they get discharged, and then they come back and they take a dose of this. This is our protocol. The most important, again, with respect to this disease of what happens is before any of this occurs. Every case I look at in the chart and look at kind of armed with a retroscope and chagrin, this shouldn't have happened in the first place. Actually, I saw a patient today in the hospital in St. Paul about 2 weeks ago. Got a dose, 3 doses of antibiotics because he looked sick. It was a hypoglycemic episode unrelated to this, but just looked kind of shocky. And they gave him antibiotics, went home. Unfortunately, his wife has cognitive impairment, couldn't really observe there's any changes, couldn't really see the clinical change. Then he's admitted again with coma to the hospital, anuric. And it took a couple days for physicians to sort out that the C. diff is in play. And it's actually a pretty remarkable case of pseudomembranous disease where 85% of his colon is just covered with pseudomembranous crust. But now we see the patient. It is what it is. So our protocol is, I think we need to be prompt on this. If there's no adequate response to antibiotics, and of course there's guidelines for that, 500 vancomycin QID, IV flagyl, no response, it's still fulminant. If the Atlas score is greater than 5, that means there is real chance of death, like 20% or 30%. We should be doing colonoscopy. We try to stop the antibiotics, do a gentle wash. They generally have ileus, but tolerate the 2 liters of go lightly. If they do have megacolon and pneumatosis, I think it's a little late for us. Then it becomes a surgical case, I think. Generally, they become better. We do follow daily white count and CRP, and if that's not improving, we may repeat it. Sometime on day 4, they're doing quite well, and at that point, before their symptoms recur, just start vancomycin again, and you'll probably be able to discharge them from the hospital. And then they come back as outpatient and get their capsule treatment, which is just 4 capsules. Unless they have dysphagia or something, then you can repeat it colonoscopically. So once again, back to the take-home message. At this point, I'm not sheepish anymore. I think this should be the first-line therapy for this disease. It's a highly, it's a disease that has high morbidity and mortality. Most importantly, we should be considering it early. We actually always get a colorectal surgery consult alongside, make sure we're all on the same team. We wish our medical colleagues would call GI and not ID alone, and call all of us together so we can be all in agreement what's best for the patient. And I believe we still need to do a lot more education on this. That's the end of my talk. So there is an organization called Open Biome. They're a nonprofit. You can buy that material. I'm not sure because we have this, so I'm not sure how quickly you can mobilize that, but probably fairly quickly, at least, but you should be thinking of it ahead. Because as a therapeutic material, we haven't gone out and distributed to other hospitals. I think we're probably close to that point, or we should probably think of that as a possibility, but I'm sure there's some regulatory steps that we have to overcome. Otherwise, we're happy to accept the patient and jump on it quickly as well. Yeah, so Open Biome is this nonprofit operating out of Boston. The regulatory part of this is an interesting story in itself, but the FDA allows this to happen, and so Open Biome contracts with healthcare organizations and sells this material directly to pharmacies, and then the pharmacy stores it in their freezer.
If I can repeat the question real quick. The question is, who really is the pivot point person? Is it the ID GI colorectal surgery in terms of recommending that the patient receive this therapy?
I totally agree with you, and it's in part on us to do the education more than just, even in our hospital, we're finding that our hospitalists are not aware that this is an available therapy, and we've described this. So that's clearly a barrier, and a lot more education needs to be done. I think you're aware of it. You can call us immediately. I'm happy to talk to ID, review the data, and basically present what the options are. I think the patient's family needs to know what the options are.
Question is,
yes.
Is there a difference in administration techniques to the results of the therapy?
The experience is fairly limited, but I don't like the idea of NG tube administration to patients that have ileus. I'm not sure how well it's going to get there, and there's potential for aspiration, which in fact has been described, and you can end up with microbes completely in the wrong place. So that's one consideration. Colleen Kelly in Rhode Island does this in their protocol. They infuse it by enemas, just like Benign did in the 1950s. That's probably fine. The only objection to that, the main objection to that I have is that sometimes you're wrong. And these patients look really, really sick, and they test positive for C. diff, but that doesn't mean that they have Fulminant C. diff colitis. They may have completely something else, and we've certainly encountered those cases. So just actually seeing the pseudomembranes with the first colonoscopy is helpful to nail the diagnosis and that you're treating the right things. So I like the colonoscopic infusion first. So the question is, maybe we should be jumping into this even earlier. Well, there's several factors. One is, there are guidelines, and this is the therapy for fulminant colitis, so I don't necessarily want to dispel that quite yet. Also, I don't know whether just getting some vanco on board to kill the C. diff may actually be a beneficial part. The reality is, it's never 2 days. It's more like a week or 10 days until suddenly it becomes an emergency. So I don't think this is. I've never seen that this is too early. In retrospect, that they come with antibiotic history. It's a lot simpler. It's a lot simpler to do. We had some of the failures we've had where I had 2 patients and they both had fairly tight sigmoid strictures, and in those cases, the benefits seemed to be minimal. I just didn't see that CRP drop, and there was no clinical improvement. I think it's important to be able to clear the toxin. I think they should be having bowel movements. We're having one case in the hospital right now. There's no way he's going to have surgery. It's 100% mortality. He's anuric on the vent, too far gone. But his ileus is still not quite recovering. He's starting to have some tickles of bowel sounds. But I worry that the ileus that just doesn't recover may be the same situation, that there's still too much of the toxin inside. We actually wrestled the ID into giving him bezlotoxumab, which is an antibody against the toxin. There is absolutely no data whether that works in this situation, but it seemed like a good idea. Oh, no.
The question is, do you go to the cecum every time? I was going to ask that with the sigmoid strictures.
I mean, enemas worked. So I think that the goal is to deliver the microbes. They'll find their way. I advanced the scope very gently because this is a pretty fragile colon with using CO2 insufflation. Generally just reach past the splenic flexure and the transverse and don't force any, you try not to introduce any loops. Be very respectful of the colon that's that sick.
Question about the use of Questran as an absorptive agent for C. diff toxin.
The guidelines right now advise against Questran primarily because it binds up vancomycin. So in treatment of at least outpatient C. diff, that proved to be detrimental. Whether in fulminant disease it has any role, I'm not aware of the data.
I want to thank Dr. Khoruts very much. We're going to